Hello everyone, this is a case of TLH BSO for a deep infiltrating endometriosis in a 34-year-old lady with previous to cesarean section with complaining of severe dysmenorrhea and dyspareunia since 5 years and with the history of endometriosis surgery 3 years back, and now she was posted for total laparoscopic hysterectomy and bilateral salpingo-oophorectomy. This was the initial endoscopic view of the pelvis. For the TLH and BSO, our first standard step is sigmoid mobilization and dissection at the brim to identify the ureter and the surrounding structures. As usual, just we have to start the dissection from a virgin plane, and it's almost always from the brim. We identified here the left ureter, and further dissection was carried out to dissect the ureter till deep. Later on, the sigmoid was mobilized away from this tubo-ovarian mass, and we did not puncture the TO mass because the cystic mass will provide us the good traction and counter traction. Gentle dissection was carried out here to dissect the bowel away from this TO mass. A blunt dissection will help to dissect this bowel. Few more cuts were applied to dissect the bowel away from this TO mass. Whenever we face the bleeding or oozing, we have to tackle it at that particular time so that this will not spoil our field of dissection. After this dissection of the bowel, we have to dissect again on the left tiomas. So the further dissection on the left side was carried out, and for this now we have started and used the lateral approach to dissect out the retroperitoneal structures. The IP ligament was stretched out medially, and the internal iliac artery, uterine artery, and ureter were well identified. The uterine artery was ligated at its origin to reduce the vascularity of the uterus. Then a window was created for the IP ligament, and proper coagulation and cutting of the IP ligament was carried out, and this will reduce the vascularity of the ovaries and fallopian tube and the uterus. By this step, we have achieved the 50% of the blood circulation to the uterus was gone. Then the remaining bowel was being dissected with short burst of cutting current as well as the blunt dissection. But here the dissection should be very gentle, and the traction which was given by the needle holder is also very gentle, not to damage the bowel. Then the remaining fibers of the tiomas were dissected to release it from the lateral pelvic wall, and the ureter was being dissected away from this tiomas in a very gentle manner. The ureter was being dissected away from this tiomas by means of blunt as well as the sharp dissection, and we have to make the ureter free from these adhesions. These few remaining fibers were being cut down. After completing the dissection on the left side, we have approached the same retroperitoneal approach towards the right side. First, we have dissected the ureter very deep. Then the bowel was dissected away from the right tiomas. A proper plane was achieved by blunt as well as the sharp dissection. And the rectum was released away from these adhesions, and we reached in the lateral pararectal space deep down. But before that, we have to secure the vascularity. So the uterine artery and the ureter were dissected on the lateral pararectal space. Ureter was being dissected carefully deep down, and the internal iliac artery was identified, dissected well, and the uterine artery at the origin was well coagulated to reduce the blood supply to the uterus. For this coagulation, we use the coagulation current with the bipolar shearer, and then the same window was made for the IP ligament, and after a proper coagulation, the IP ligament was cut down. Now the blood supply to the both adnexus and uterus is completely cut off. The right ureter was densely adherent to this right tiomus, so proper gentle dissection was carried out in the form of sharp as well as the blunt dissection. Here the tiomas which helped us in the dissection, so we did not puncture the tiomas, and these are intact. After securing the both ureters and cutting the both uterine arteries at the origin, our further dissection was to the rectum. The cyst was here accidentally ruptured and hemorrhagic fluid was seeped out. Now the most important part of the surgery is the rectal dissection is remaining, and we are trying to dissect it in a gentle manner. For the rectal dissection, we have to dissect it laterally first, then in the center. Fiber by fiber dissection and the proper identification of the tissue planes is very important to dissect this rectum. You can see we are trying to dissect it very gently by the blunt action, and we went deep down on the both sides of the rectum. Then securing the rectum, we cut the middle portion of the adhesion, but very gently. Gentle cuts were made. Blunt as well as the sharp dissection was carried out here to dissect out the rectum away from the cervix and the vaginal wall. Now we have entered into the clear plane. The both leaves of the denodal fascia are being opened, but it's slightly difficult because of the endometriotic adhesions. So blunt as well as the sharp dissection was carried out here to dissect the rectum. For this, the proper traction is being maintained for the cutting and the blunt dissection. Now we have reached deep in the pelvis and the rectum was dissected away. Now further dissection for the ureter was carried out till the tunnel, and we secured the ureter deep down. The posterior dissection is almost complete, so we started to dissect for the bladder. As this is previous to cesarean section case, so the bladder is adherent densely at some places. After holding and giving traction to the bladder on the anterior side, gentle cuts are made, trying to find a proper plane. This is the dense adhesion band and we have to cut it only. And we got a proper plane in between the bladder and the cervix. The key of the bladder dissection for the previous surgical bladders, we should hold the whole bladder anteriorly and giving the traction to the uterus posteriorly, and the CO2 gas itself will provide us a proper plane to dissect the bladder down. Here we can see very few sharp cuts are made, otherwise the bladder is dissected deep down by the blunt traction only. Few fibers on the right lateral part are being cut and the bladder is dissected deep down. Now the bladder is again held and traction was given anteriorly and the remaining part of the bladder was dissected, and now you can see the bladder is dissected very deep down, and if we need arises we can further dissect the bladder down. So the next step is uterine vasculature ligation on the left side. So first we have to dissect the fibers of the connective tissue, and then the bladder was uphold and slightly dissect deep down on the left side. Then the step is the uterine vasculature ligation. For this ligation, we don't need to skeletonize the uterine artery and vein and the vessels separately. So we have to coagulate the whole bunch and then cut it open and lateralize it very well. You can see the rotation movement of the shearer tip for the cutting and the lateralization are different. Now we can see the vagina will be opened here at the insertion of the uterosacral ligament. Before opening the vault, we have to dissect on the right side also. So the whole bladder was stretched up and some more dissection was carried out on the right lateral side. The bladder is dissected very deep, then few fibers which are remaining are cut open. For this dissection, we have to make the ureter in vision. As the ureter is very far, because of the traction was given to the opposite shoulder tip and proper coagulation of this vasculature bundle was made, and then these vessels were cut. After cutting these vessels, we have to lateralize these very well till the opening of the vaginal vault at the level of insertion of the uterosacral ligament. Now we can see we have properly lateralized the vasculature bundle and we have to start the cutting of the vault. For this case, we started the vault cutting on the anterior side and then we increase it circumferentially to detach the uterus out completely from the vagina. For cutting, the proper traction is essential. Here the sharp cutting current was used for the vault cutting. and we have to avoid unnecessary coagulation at the vault, because unnecessary coagulation will hamper to the vault healing. This is the final cut of the vault, and the specimen was separated out from the vagina. You can see this is the whole specimen, and the specimen was delivered out intact via the vagina. After extracting the specimen out, we have to dissect the bowel furthermore, so that we can take the sutures very confidently and in the full thickness of the vaginal wall. The vaginal vault was sutured in the figure of 8 manner with the 2 stitches only by the help of number 1 vicryl. The vault was sutured, hemostasis was checked, thorough cleaning was done by the suction irrigation, and the both ureters and the rectum was checked, and everything is fine. Thank you very much for the patience watching.